Wonderful. I'm not sure if everybody can see me or not, but I will get started. Hello, everybody. Thank you so much for joining our webinar series tonight. I'm absolutely thrilled to have such a great number of attendees. The numbers are climbing. We're in the mid-50s now. So thank you again for taking time on a beautiful evening. At least it's beautiful where I'm at. I hope it's lovely where you are as well. We'd like to take our time to welcome Dr. Daniel Cordovani, who is a staff anesthesiologist at Hamilton Health Sciences, and I get to work with him, so I'm doubly thrilled. And he's also an associate professor at McMaster University, Department of Anesthesia. He's completed his Master's of Science in Health Sciences Education at McMaster University, and his training includes fellowships in advanced airway management at the Toronto General Hospital and education and simulation in anesthesia at Sunnybrook Health Sciences Centre, University of Toronto. He is an excellent speaker. This is a wonderful presentation. It's really a skill, that we rely on. So we look forward to sharing your insights with us this evening. Thank you, Dr. Cordovani. I'm going to hand that over to you now.
Thank you. Thank you all for attending this session. So I'll be talking about the management of the unanticipated difficult airway. And I have to get through some formalities. First of all, I don't have any relationships with non-profit or for-profit. So no interest, no money being gained by any industries. The objectives of the talk is, I would like you to be able to identify features of difficulty in airway management, to list the steps and equipment required for the performance of a cricothyroidotomy, and to learn some communication tools that can be useful for airway emergencies. I'm going to start with this picture that for those who are not familiar with this might not make much sense. But this is from, I will go over this again in future slides, but this is to try to highlight that essentially there are three ways to manage an airway of the unconscious patient. You either have, oh, by the way, can you see my pointer? Only so whatever I'm pointing, I can know that you guys are seeing.
I see it.
Okay, perfect. So there are three ways to manage the airway: either face mask, laryngeal mask, or tracheal tube. And the reason that I'm emphasizing starting with this image is because you will see that part of my talk will be how many of the airway management tools, guidelines, algorithms, they are a little bit convoluted, a little too complicated with lots of words and lots of errors and lots of loops around. And sometimes we forget the main message. We have three ways to manage the airway. It's either face mask, laryngeal mask, or tracheal tube. That's it. What about higher cardiac bypass? Yes, but yes, that's extremely rare. So yes, you could actually put the person on bypass and you're also sort of managing their airway. But for the purpose of simplicity, it's face mask, laryngeal mask, and tracheal tube. And the idea is, even though I'm talking here about the main focus of my talk is going to be the management of the unanticipated difficult airway, I want to spend some time trying to address how do we identify when we think it's going to be difficult. This way we don't have to deal with the unanticipated one. So yes, sometimes we will have to deal with the unanticipated one, but we should try to avoid it. So if you expect difficulty, important message is don't take away your patient's ability to breathe. So for the vast majority of the cases you see in the OR is that we put people to sleep, and after we put them to sleep, then we place the breathing tube. That's how it happens almost always. But if we know or we anticipate that it's going to be difficult, we shouldn't be gambling with the patient's life. We should try to do an awake intubation, which is more advanced airway management. It's not going to be the purpose of my talk, but it's doable and done calmly in the right circumstances. It's comfortable. It's not a traumatic experience for the patient, as long as it's done calmly with appropriate gentle sedation and good airway topicalization. A caveat to this statement is that I say, if you expect a difficult, don't take your patient's ability to breathe. this is if you have a cooperative patient, if you have the ability to do that. There will be situations in which you think it's going to be difficult, but the patient is combative or they're not cooperative, and then there will be situations in which you don't really have much of a choice. But the vast majority of the cases, particularly for elective surgeries, you have the ability to just put a foot on the brake. I don't think this is going to be easy. I'm not going to take the patient's ability to breathe away. I'm going to try to do this with the patient awake. Most likely it's going to be successful. But if it's not successful, if I give up, this patient is still breathing. I can just give up and the patient's still breathing. I never killed the patient. But first step is I have to identify when I think it's going to be difficult. And there are different ways. This is the most common way that you might have seen or heard. It's called the Mallampati score, the Mallampati classification, which essentially Mallampati 1, 2, 3, and 4. It depends on how much of the uvula and the oropharynx you can see. You can see the entirety of the uvula, 1, part of the uvula, 2. You can see a bit of soft palate, 3. You can only see hard palate, 4. This is a predictor, but I think it's also important to know that there is not one single predictor that is a very good predictor. Normally, we have to use the predictors in conjunction. So if you have just a Mallampati that is not very good, that alone might not tell you that it's difficult, but maybe this plus neck mobility or this plus mouth opening is usually a combination of predictors that will have a more significant predictive value. So there are some acronyms that I'm going to throw out there. One is LEMON, which stands for Look Externally, Evaluate 332, Mallampati, Obstruction, and Neck Mobility. And this is what the 332 is. Can you fit 3 fingers in the patient's mouth? Do you have 3 fingers of distance between the chin and the hyoid bone? And do you have 2 fingers of distance between the thyroid cartilage and the floor of the mouth? So between the thyroid cartilage and the hyoid bone. So 332, can I? This very quick bedside assessment will tell you some predictors. If you are not able to fit 3 fingers, or if it's a short thyromental distance, if it is a short thyroid hyoid distance, those are predictors of difficulty. And I also want to point out another distinction. We talk a lot about difficult intubation, but difficult intubation is often focused exclusively on anatomical features. But there is the concept of dangerous airway. And I use this silly image as an example because jumping across this is not easy. It's not difficult. It's quite easy. It's just like not a very large distance, but it is still dangerous. If you make any mistakes, the person will die. And the example that I like to use regarding dangerous airway that does not include anatomical features of difficulty is, for instance, a septic patient. You're in the OR, there's a perforated bowel, patient is septic. So they are already hypotensive, cardiovascularly unstable. Because of their septic, they are in this hypermetabolic state, so they're consuming oxygen very quickly. So this is a patient that will likely deset very quickly. And this is also a patient that could have cardiovascular instability during induction because of the induction agents that we're going to use. So even though we might have a good mouth opening, Mallampati 1, and the anatomical features might be easy, it's still a dangerous airway. And I don't want people to just focus exclusively on how easy it is to place a breathing tube in a person's mouth and trachea. You have to remember other components of the clinical care of the patient. So this was just a little bit of a side observation. And another thing that I want to emphasize is that we talk about the difficult intubation, but as I mentioned earlier, there are 3 ways to keep the unconscious person oxygenated. You have the face mask, laryngeal mask, and tracheal tube. So the predictors of difficult intubation, difficult laryngoscopy, they don't necessarily match the difficult face mask ventilation. So this is, again, the acronym for difficult bag mask ventilation, BOMS. We talk about the lemon for intubation and now BOMS for bag mask ventilation. So beard, obese, no teeth, elderly, and sleep apnea. And I think one important distinction is that it's easier to intubate a person with no teeth, but it is harder to bag mask ventilate a person with no teeth because it makes it harder to create a good seal of the face mask. Another way to remember that is BOOTS. People love acronyms. So beard, obese, old age, toothless, and snores. Same principle. Think of Santa Claus, old, beard, and obese. I will guess that he also snores and that he has no teeth. So that's the person that will likely be hard to bag mask ventilate. And there is also the difficulty to place a supraglottic airway. We often use the acronym LMA. LMA is a brand, so that's why we would normally just say supraglottic airway. So supraglottic airway, restricted mouth opening, obstruction, distorted airway, or stiff either lungs or stiff C-spine. So those are the things that would make it harder to insert a laryngeal mask successfully and ventilate a person with a laryngeal mask successfully. So I will emphasize this message. If you expect difficulty, don't take away your patient's ability to breathe, particularly if you expect difficulty not only to intubate, but if you expect difficulty to intubate and to bag mask ventilate. If there is not one clear cut that it will say, hey, if you expect this level of difficulty, you should do awake, you should not. But if you are anticipating, if it is this person that is obese with a beard and sleep apnea, no teeth, and on top of that, they have a Mallampati 4 and limited mouth opening, don't take this person's ability to breathe away, because you already have enough features of difficult intubation and you have enough features of difficult bag mask ventilation that if you take this person's ability to breathe away, you might run into trouble. And different from the awake intubation, that if you're having difficulty, you can just pause or give up and the person is still breathing. If you put them to sleep and take their ability to breathe away, now you're into trouble. But now coming back to the focus of this talk, which is what to do if you do encounter an unexpected difficulty. So hopefully by having those tools, lemon, bones, and rods, you know how to anticipate when the airway management will be difficult and you will not have to run into this situation. But let's say those features were not present and now you did your regular induction and now you're going to intubate, or you're present in the situation like that and it was hard to intubate. What to do next? This is the image. If one is not working, which is a tracheal intubation, what about face mask? What about laryngeal mask? This image over here is as if I were looking from above this image over here. This is called the vortex approach. So I would encourage you, there is a short video, it takes about 10 minutes in their introduction to this principles of the vortex approach. I would encourage you to watch this video. I did not include in this talk because it would take too much time of the talk. But if you go to vortexapproach.org, you will encounter the video. But I will explain briefly what it is. Any person who is not being oxygenated, we consider them to be going down the vortex. So essentially, my patient is awake, I'm pre-oxygenating them, I tell them, take a deep breath, take a deep breath. They are being oxygenated because they're breathing spontaneously. So they are in what we call the green zone. As soon as I put them to sleep and take their ability to breathe away, they are immediately going down the vortex. They're not being oxygenated. Now I'm going to try a few things. Typically, we bag mask ventilate the person. If bag mask ventilation is working, the patient is back in the green zone. If bag mask ventilation is not working, I have to try something else. And you essentially have to remember that bag mask ventilation, tracheal tube, and laryngeal mask are your three options. Assuming you exhausted your best attempt of bag mask, you exhausted your best attempt at tracheal intubation, exhausted your best attempt at laryngeal mask insertion, you ran out of options. You're going to have to do the cricothyroidotomy, and that's what this symbol is over here, is the cricothyroidotomy for you to go back to the green zone. So to go back to the image, this is looking from above. This would be a 3D representation. I'm trying one of the three. If one of the three is working, you have time to think. If none of the three is working, you have to do the cricothyroidotomy. So whenever one of them is working, you are in what's called the green zone. And this is just to simplify communication, which is one of the things that I'm going to talk here as well. And there is no particular order that the vortex approach prescribes. It could go from it could start at the tracheal tube and go to laryngeal mask, or it could start laryngeal mask. There is no particular order. The message is simple, and I am intentionally being very repetitive. Face mask, laryngeal mask, and tracheal tube. If one of them is working, you are in the green zone. You may not be doing exactly what you intended, but you have the ability to keep the person awake. If none of them is working, it's time to go for the cricothyroidotomy. The difficulty with the cricothyroidotomy is not necessarily to perform it, it's to decide to do it. So this becomes a cognitive aid to help people decide it. And this is the cricothyroidotomy technique that I advocate people practice and know about. That's the one that is recommended by the Difficult Airway Society. And this is a short video explaining it.
Before attempting a cricothyroidotomy, announce that this is a can't intubate, can't oxygenate situation and call for help. Continue attempts to oxygenate from above and ensure that the patient is paralyzed to exclude laryngospasm. Position the patient to extend their neck. Stand on the patient's left. Using your left hand, perform a laryngeal handshake to identify the larynx and place your index finger on the cricothyroid membrane. Stabilize the larynx using your left hand and stretch the skin taut between your fingers and thumb. Holding the scalpel in your right hand, make a transverse stab incision through the skin and cricothyroid membrane with the cutting edge of the blade facing towards you. You'll feel a pop as the scalpel enters the trachea. Keep the scalpel perpendicular to the skin and turn it through 90 degrees so the sharp edge points to the feet. Swap your hands so you are holding the scalpel with your left hand. Maintain gentle traction, pulling the scalpel towards you to maintain a triangular incision, but keep the scalpel handle upright at 90 degrees to the skin. Taking the bougie in your right hand so it is parallel to the floor and at right angles to the plane of the trachea, push the angled tip down the scalpel blade, keeping contact with the blade until the bougie is in the trachea. Rotate the bougie to align with the trachea and advance gently up to 10 to 15 centimeters. Remove the scalpel. Advance a size 6 tracheal tube into the trachea, continuously rotating the tube as you advance it. Try to avoid excessive advancement of the tube. Remove the bougie. Attach the circuit and give oxygen. Inflate the cuff. Confirm ventilation with capnography.
So I think what is important about this particular technique, and I will emphasize that, is the simplicity. So that's the equipment: a scalpel, blade 10, bougie, and a size 6 endotracheal tube. That's it. And those are typically devices that are readily available in most operating rooms. It's still helpful if they are combined in a small package, so we don't have to fetch for them independently. But that's it: scalpel, bougie, tracheal tube. And this is how in some institutions it's just done, just a Ziploc bag, and then you put the equipment inside. And one of the other advantages of that, instead of having a commercially available kit, is that those commercially available kits, with they cost over $100 each, they will expire. Hopefully they will not be used, but then they expire. Versus this one, you can keep it, and when the instruments within this content are about to expire, you can just use in an elective case. You can just use the endotracheal tube, the scalpel in some other case, and replace with something else. So it would also be cost effective in the sense that it would be a kit that sort of never expires. When I do a workshop for ICU fellows and anesthesia residents every year, so in which I teach how to do cricothyroidomy in pig larynxes. We use that, and I used to teach how to do with this particular kit. And I used to be a big fan of that because my rationale was like, oh, this one gives the option of using the surgical technique, if you prefer this way, or to use the Seldinger technique, so the guide wire technique, if you prefer this way. I no longer feel this way. This giving option in the middle of the emergency might not be so ideal, particularly this kit, which has so many different small pieces, loose pieces, and then people are not familiar with the device. And then you're learning in the middle of the emergency, assembling things, small little pieces that fall. There is this talk on TED, which is called The Paradox of Choice. It's obviously not about airway management, but I think is an interesting, you can make an interesting parallel about how sometimes having too much option might be detrimental. And the author talks about other situations, such like investments, in which maybe there are too many products to invest on, and people have like this choice paralysis. They don't buy any investments, like because there are so many different ETFs or funds or whatever, and then they don't know what's best and they don't buy anything. Or other consumer products in which, because there are so many options, you spend so much time debating what's best. That's not exactly the decision of airway management, but I do like to parallel to say that in the middle of the emergency, it's probably not to have to deal with this extra component of cognitive load. Just go with one thing that is simple and that has been proved, that's a track record of working well. I think it's important to remember that as our stress level increase, our ability to see, to think, and to perform actions like motor skills, they all decrease. And that's exactly the situation in the middle of the cannot intubate, cannot oxygenate situation. That's probably the most stressful situation for being, at least for anesthesiologists. And this is the moment that you need to have good motor skills, vision, and cognitive processing. And that's exactly the moment that your peripheral vision is kind of lost, your cognitive processing is also diminished, and your fine motor skills have also lost its ability to properly perform the procedures that you want. So this is from the difficult airway guidelines. There is this statement that I think is important. Cognitive processing and motor skills decline under stress. A simple plan to rescue the airway using familiar equipment and rehearsed techniques is likely to increase the chance of a successful outcome. And going back to this device over here, those are a lot of things that we're not familiar with, like a tracheal hook, trousseau dilator, and all those other, like this introducer that goes inside the cannula. Those are often devices that the team dealing with airway management might not be familiar. But a scalpel, a bougie, and a tracheal tube, those are devices that people are familiar with. And I like to show this that I just stole from Dr. Paul Baker, who is an anesthesiologist. When he did a presentation in Toronto a few years back, I just stole this slide from him. Because I absolutely love it. Anesthesiologists, which are supposed to be the airway experts, they were only successful 37%. Only 37% of the time they were successful in performing surgical airway, emergency front of the neck access. But in comparison to the military literature, combatants with no military training, with no medical training, were successful 67% of the times, and combatants, military personnel with medical training, they were successful 85% of the times. And those are including the battlefield, performing emergency front of the neck access in the battlefield. So they have way more stress than an anesthesiologist in a protected environment. So airway expert, 37%. No medical training, 67% success rate. And why that is, I cannot prove that, but I would argue that the military people, they only practice one technique. So they practice simulated situations, and those had medical training, but they also practice simulated situations, and they only practiced one technique. Versus anesthesiologists is the problem of the choice. Because they're perceived as the airway experts, we are often trained in different techniques. Is the needle technique, the guide wire technique, the surgical technique, and there is this surgical, and there is this other surgical technique. And because we are supposed to be the airway experts, we are presented all of that. But this is a rare event in which most people will not see in their careers, or see once, maybe twice in their careers. So you cannot be good in something that you're not practicing. but because they are perceived as the airway experts, they are presented with all that. So they are basically crappy in a whole bunch of different techniques, as opposed to be really good in one single technique. And just a small distinction, I don't know, I apologize if this is an obvious statement, but I know from, at least from learners working with me in the OR, I know that for them it's not always obvious. Cricothyroidotomy versus tracheostomy. So cricothyroidotomy is anything that is happening over here in between the cricoid cartilage and the thyroid cartilage. So you have the thyroid cartilage, cricoid cartilage. Here you have the cricothyroid membrane. If you are accessing the airway from here, accessing the way from here, it's a cricothyroidotomy. If you're doing anything below the first ring, that's tracheostomy. Typically, although tracheostomy are done also in some emergency situations, for the most part, the emergency front of the neck access, so a rescue airway in the cannot intubate, cannot oxygenate, sometimes also called cannot intubate, cannot ventilate. I'm not going to go into semantics. They all refer to the same thing. Typically, we're talking about cricothyroidotomy. Tracheostomy typically take a little bit longer to do it. So I want to present a bit of also historical perspective. In 2005, there was a survey distributed to Canadian anesthesiologists asking what would you do in a cannot intubate, cannot ventilate scenario. 2005, most anesthesiologists in Canada said that they would do a cricothyroidotomy by IV catheter. So put an IV in the cricothyroid membrane and try to ventilate through that. And some people would prefer percutaneous dilation, which is the wire technique, and then you dilate. And open surgical cricothyroidotomy was only 7% of people. 2005, that's what the Canadian anesthesiologists said they would prefer to do. But let's see what actually happened when real situations of cannot intubate, cannot oxygenate occurred. And then I'm bringing you to the UK. In the UK, they did this 3-year audit of major airway complications. So it's essentially encompassing all of the United Kingdom, all of the times in which there was some massive major airway complication. And in the 3-year audit, so real case scenarios, they analyzed that there were 133 serious complications of airway management. Out of these 133, 58 involved an attempt at a cricothyroidotomy or tracheostomy. So 58 cases in real life in which this happened. Out of those 58, 33 times the anesthesiologist just asked for the surgical colleague to do the surgical airway. Anesthesiologists themselves tried to do the surgical airway in 25% of the times, or emergency front of the neck access. They tried to do 25 times, 25 out of the 58. Only 9 of those 25 attempts were successful. So the big airway experts pretty much sucked at performing emergency front of the neck access. That's where I got this. So anesthesiologists are saying, at least in Canada, they're saying, we prefer IV or percutaneous dilation, put a guide wire. But in reality, for the most of the time, they asked somebody else to do it for them. And when they tried it, they were not successful. And that's what happened. Anesthetists almost exclusively chose cannula techniques to try to rescue the airway, but the use of these devices was associated with a significant failure rate. So just for terminology, what I'll say either cannula or surgical. Cannula would mean something like you put an IV catheter, a wire, dilation, and surgical would mean you're using a scalpel to cut the neck and get access to the airway. And remember, Canadian anesthesiologists said that their preferred technique was IV catheter. So needle cricothyroidotomy was attempted in 3 cases in real life. None of those 3 cases, it was successful. So the preferred technique by Canadian anesthesiologists in 2005 failed all of the times that it happened in the UK. So those are some of the executive summary statements. A surgical technique for emergency surgical airway was almost universally successful. So when the surgeons did it, they normally did this open surgical because that's what they used to, and almost always it was successful. And back then in 2011, they raised the possibility that cannula technique is inferior to a surgical technique, and the anesthetist should be trained to perform a surgical airway. So 2011, they're pretty much saying, hey, anesthesiologists, I know that you guys like needles and wires and more than scalpels, but maybe you should learn how to do this other way. In 2014, there was a repeat of that survey to Canadian anesthesiologists. It hadn't really changed all that much yet. So IV catheter was no longer the preferred, but it was still a cannula technique, a wire guider technique. The scalpel bougie technique or some form of surgical airway was still at the bottom of the preferences. But now what we know is that any surgical technique is better than cannula in terms of success rate. We don't know exactly which surgical technique is best, but we know that surgical is better than cannula. And now I'm just going to regurgitate some articles, kind of like to, just so you know that I'm not pulling this, I'm not just manifesting an opinion. It is based on some evidence. So there was this meta-analysis of pre-hospital airway management, and in this pre-hospital airway management meta-analysis, they demonstrated that needle techniques were successful 65% of the times, but surgical techniques were successful 90% of the times. And the range from the studies went from 42 to 83, and here 84 to 94. So the success rate with surgical techniques higher in this systematic review and meta-analysis. This is a short report of 2 anesthesiologists that they were also working pre-hospital setting in rescue missions, and those anesthesiologists, they had a career combined. Together they had a total of 24 successful cases of a scalpel finger tube technique. So I showed the video of scalpel, breathing tube, scalpel, put the bougie, and then put the breathing tube. Those anesthesiologists, they are describing the technique that they use, which is a scalpel, that they use their finger to dilate and then put a breathing tube. And they were successful in 24 times. There is this commentary from the Scandinavian Journal of Trauma, Resuscitation, and Emergency Medicine, in which the authors, in their assessment of the literature, they say that there is no good evidence supporting needle crical. Needle crical associated with failure and complication, and there was no evidence that commercially available products were better than surgical technique. On the other hand, surgical crical has good success rate, and they were already recommending that. That was 2013, shortly after the NAP4, saying that future airway management should consider promotion of surgical airway over needle crical and commercially available kits. In 2014, the British Journal of Anesthesia published this observational study that included like thousands of failed airway techniques in trauma patients. And out of all those patients, they had a total of 48 cases of successful intubation with the scalpel bougie technique that I described in the video. 48 scalpel bougie procedures with 100% success. So this influenced the Difficult Airway Society in the UK in 2015 to launch their guidelines of the management of the unanticipated difficult intubation. And for adults, they were saying that the scalpel bougie tube technique is the technique that should be taught and used as the default. So they're no longer promoting guide wires, IV, and they're promoting a surgical technique. And out of the surgical techniques, as I mentioned, there are many different ones. I just described one that they put the finger, but they are describing one. And the reason for describing this one is specific. It's not because we know for sure that this technique is better than the others. It's because this one is simple using readily available devices. We're not using a tracheal hood, trousseau. We're not using crazy things that are not readily available. It's things that are readily available. The scalpel finger tube, although it's also using readily available tube devices, the one disadvantage that I would argue over the scalpel bougie is that you access the airway, but then once you remove the finger, you lose the airway, and then you have to put a breathing tube again, versus the scalpel bougie technique, you always have something inside the trachea. So it's either your scalpel that is inside the trachea, or it is your bougie, or it is your breathing tube. There is no moment that you lose access to the lumen of the trachea. There has been no other national survey after those guidelines. So remember, 2005, anesthesiologists in Canada said, we prefer IV. 2011, NAP4 says, hey, IV doesn't work very well. We should be using surgical. 2014, the anesthesiologists in Canada say, yeah, we still prefer cannula. No longer IV, but we still prefer cannula, and surgical is still our last option. And then 2015, the CAS is saying unequivocally we should be doing surgical. What we did, this is a recently publication in the Canadian Journal of Anesthesia. We surveyed the anesthesia residency training programs in Canada. And what we know now is that for front of neck access, primarily scalpel bougie is the preferred technique being taught in the programs. There is still one program that is teaching Seldinger. Seldinger means Seldinger technique is whenever you place a needle, then you put a guide wire, and then you dilate, much like when we do central lines. So there is still one program that prefers the Seldinger. Majority of the programs prefer the scalpel bougie, and you have 3 other programs that prefer some other type of surgical. So this is good in the sense that the preferred method being taught to the residents is what is currently being recommended by the airway societies. Having said that, there was still one problem that we identified in the survey, which is this is the preferred method, but the residents are still being taught multiple ones. So even though they prefer to teach the scalpel bougie, they still teach the other ones as well. And I find it problematic because, as I mentioned, you cannot be good in something that you don't see often, that you don't practice often. So instead of knowing how to perform something fairly well, or like poorly in different devices, I would prefer to devote the training exclusively to one technique and allow them to train more times. We should make it easy to do the right thing. That's a statement from Martin Bromley, who is the husband of Elaine Bromley, which is a case that I will describe in a few moments. And the reason I'm emphasizing this, you should make it easy to do the right thing, is that the airway guidelines, airway algorithms, they don't necessarily make it easy. When I was describing the 3 different ways to keep a person oxygenated when they're unconscious, I mentioned face mask, laryngeal mask, tracheal tube. That's simple. When you look at the American Society of Anesthesiologists difficult airway algorithm, that's not a clear message over here. If you think over here, it's like intubation was not successful. Is face mask ventilation adequate? Okay, it is adequate. So it's a non-emergence pathway. It's not adequate. You consider the supraglottic airway. Supraglottic airway is not adequate. So you have to do emergency pathway. It's a whole bunch of errors, and it's complicated and convoluted. And so one person might say, yeah, but this is from 2013. I know for a fact that they updated their guidelines. Yes, they did. So that's the 2022. It doesn't make any more, it doesn't make any simpler. It still has a whole bunch of errors. Go this way, that way. You still have a whole bunch of things written. So this is a very useful tool, but I would argue that it's a very useful tool for a person to learn about airway management, but it's not necessarily a very useful tool during the emergency. It would be very hard to consult this algorithm in the middle of the emergency to know what to do next, versus that image of the vortex. It's simple. It's either face mask, laryngeal mask, tracheal tube, and there are some short prompts. Here, you have a whole bunch of errors, a whole bunch of words, and a whole bunch of explanation. The Difficult Airway Society, they try to do it a little bit more aesthetic pleasing. So it's more linear. You see here, it's like plan way A, did it work? Fine. Plan didn't work, plan B. Plan B didn't work, plan C. Plan C didn't work. You declare that it's a cannot intubate, cannot oxygenate, and you do this scalpel cricothyroidotomy. So they made it more aesthetically pleasing and linear, so it's easier to follow. but it's still not as simple as the cognitive aid that is the vortex approach. And this is the cognitive aid of the vortex approach. Face mask, laryngeal mask, tracheal tube. And then there are some short prompts, such as, do we need to do an additional manipulation of the larynx or devices? Do you need an adjunct, such as oropharyngeal airway? Do we need a different size laryngoscope or a different type of laryngoscope? Do we need suction? Muscle tone, which is an important one, is incredibly easier to bag mask, to intubate, and to use face laryngeal mask in a person who is paralyzed. So maybe the initial intention was not to paralyze the patient, but if you are in the middle of the airway emergency, you should strongly consider giving a paralytic agent, because that's going to make it easier to manage the airway. So this is the prompt. I find this way simpler than this, and definitely simpler than this. And that's what I was trying to assess. They say with make it easy, you have to make it easy to do the right thing. And that includes the vortex approach, includes not only a cognitive aid tool and also terminology, like a language to try to deal with airway, but it also goes about how you organize your difficult airway cart. So this is how they advocate. And all of those things, by the way, are available for free in their website. You can go there, you can print those stickers for free. If you look, this is how they advocate, but this is how it's often in many hospitals. You have a whole bunch of labels, a whole bunch of things written where you can't immediately identify what's in each drawer. Over here, from the distance, you're not reading a whole bunch of stuff. You just identify by the symbol and by the big letters. Here's face mask, here's supraglottic airway, here's endotracheal tube, here's the cannot intubate, cannot oxygenate rescue. And the green zone is like, okay, we are in the green zone. What do we do next? And you open that and you have additional resources and prompts as well as equipments. So in your institutions, you should consider just visiting the Vortex Approach website. And if your airway cart looks like this, you might want to consider to make it look more like this. And this is, which is not the, I'm not going to play this video because it takes 14 minutes. But if you want to just save this, vimeo.com and this number, it will take you to this reenactment of Elaine Bromley case. So that's the case that I just mentioned, Martin Bromley. He's been advocating for safe airway management for many years, and this is because of what happened to his wife. Watch this video. It's nerve-wracking. It's a reenactment, but this is the summary of what happened. Instead of me talking, because I have an accent and my voice is not so nice, what I will do, I'm just going to pause for a minute to allow you to read this. So a 37-year-old woman, fairly healthy, going for a relatively straightforward intubation procedure. The plan was to use a laryngeal mask. They put her to sleep. They couldn't really ventilate her with the laryngeal mask. Tried to intubate, couldn't. Back mask was not very good. And eventually they tried to give up and sort of allow her to wake up. But at that point, she had been hypoxemic for so long. She had permanent brain damage. Eventually, they withdrew care and she died. The physicians and the nurses involved in her care were considered competent. And we know that failure to intubate is a risk of anesthesia, and there are guidelines for cannot intubate, cannot ventilate. So what happened here? It was not deemed that they were incompetent. They were skilled people. There were 3 anesthesiologists, skilled nurses present. The lessons learned from this care concluded the following. There was loss of situational awareness. So the anesthesiologists, they were focused on intubation and they lost sight of the overall clinical condition. There was lack of leadership. An overall leader was required to facilitate communication and decision-making. There was not a clear defined leader for the management of this emergency. Cognition dispositions. So the team, particularly the anesthesiologist, they focused on endotracheal intubation as a solution to this stressful situation, and they did not consider the guideline protocol. So they were very focused on the one solution, which was intubation, and forgot to apply what they should be applying. And there was also what was considered a failure to communicate assertively. And in this case, it refers particularly to the nurses. So some of the nurses recognized the situation that was unfolding and made the surgical airway equipment available. But the operating room culture and hierarchies interfered with the nurses voicing their warnings, and they did not know how to speak up effectively. So when you watch the video of the reenactment, it's really nerve-wracking to see the nurses trying to nudge the anesthesiologist in the right direction, but not really being effective. And I want to share with you something that is kind of like what is going through the anesthesiologist's mind and some of the difficulties that we will face in an airway emergency. So this image over here is more typical for like a trauma center, a trauma resuscitation, or a cold situation in which the team leader is at the foot of the bed. This person is not involved in procedures. So this person is supposed to have overall view of the situation and help guide the team in the right direction, and include a person to perform CPR, another person to alternate because they get tired, somebody to manage the crash cart, somebody to record what is happening, somebody to administer drugs, a person to do the IV, and the airway manager, which typically going to be the anesthesiologist. So when we got called in a trauma situation, the anesthesiologist will often go to the head of the bed and will be focused on air management, but you have another team leader. That's not what happens in the OR when we have an airway emergency. What often happens is the anesthesiologist assumes both of the role of the team leader and the role of the airway manager. And this is problematic because it's very hard to have an overall picture of what's happening when you are so focused on a task. So this is one of the things that could occur in the middle of the emergency, and that's one of the importances of calling for help. And when there is this call for help, if there is, for instance, another anesthesiologist that arrives, the new anesthesiologist should either take the role of the team leader or of the airway manager. But we are so used to just going to the head of the bed to help with the airway that we may fail to have one person dedicated for overall picture. That's a problem that will happen in the OR. This cognitive aid will help bring a common language for all team members. The airway management is a team sport, it's not an individual sport. And most of the airway guidelines are too focused on the anesthesiologist. I like this one because this one uses easy to understand images, a simple language, and it's something that tries to unify how everybody perceives the airway. And by having this cognitive aid, it can also facilitate, for instance, a nurse that might need to prompt the anesthesiologist to say, you already exhausted your best attempt at face mask ventilation, or you already tried it 3 times with tracheal tube. Is the patient paralyzed? Do you want to consider the laryngeal mask? Because you have this cognitive aid, it is something that makes it easier because you're kind of like just, okay, I'm just using the cognitive aid over here. But it is hard to speak up. When I know that not always when I witness something, I will not always that we will speak up. And the OR is a very conflict-rich environment. We don't always want to get into conflict. But there are a few situations that we should. Those are some of the challenges that have been identified. The Canadian the CMPA is essentially the institution to use to support physicians, particularly with legal matters, and they have many useful resources. And those are some of the things that identify in this one online module that they have. Not want to appear ignorant or incompetent, not feeling confident in your observations, fear of being judged negatively, fear of embarrassment, lack of knowledge about how to speak up effectively, believing it is the wrong time and not wanting to interrupt, intimidation by other healthcare providers, and workplace culture that does not support psychological safety. Unfortunately, I don't have a magical solution, and a lot of the things are really more related to the culture of the place and the policies in place in the place where you work. So you should have a workplace culture that supports psychological safety. You should have an institution that try to bring down hierarchical concerns. But there are at least some ways that have been described on how you can speak up effectively in a situation that you feel important to do so. And this is one method is called the graded assertiveness. So CUS, I'm concerned. You tried once, and that really didn't bring the attention of the person you're trying to bring the attention to change what they're doing, or at least to acknowledge you and give you an answer. If that doesn't work, second time, I'm uncomfortable, or I think this is unsafe. That didn't work. A little bit later, you can say, I'm scared, or this is a safety issue. So this is a graded assertiveness model. And hopefully, the person to whom we were trying to address, if they also have some sort of training on that, hopefully this person will recognize when you said, I'm concerned, maybe they didn't hear, but now you said, I'm uncomfortable. Maybe this person, if they have the same training, or if they heard of this again, they know that this is being tried to be used, this is trying to be used on them to catch their attention. So strike one, didn't work, strike two, strike three. I'm concerned, I'm uncomfortable, I'm scared. That's one way to try to bring your concerns. But the assertiveness should be respectful. It's not supposed to be aggressive. It's not supposed to attack the individual. It should be focused on the specific action, on the specific case, not on the person. It does have to be appropriately timed. And constructive and focused on achieving clarification and a solution. Again, it's not focused on attacking a person. It's not about the person's, it's not about making a statement about the person. It's about something specific about the situation. And also supposed to be mindful of the clinical experience and wisdom of others. And I experience this a lot because I have learners with me often in the OR, and some situations that sometimes like a very short-lived hypotension in the patient, I don't know, after induction. This is something that could really stress out a junior learner. And I know that like in about 30 seconds to 1 minute, this blood pressure is not going to be so low anymore. So I'm not so worried. So sometimes the medical student, for instance, will try to catch my attention, and I hear that. I just address that, but I would be upset if the medical student were sort of attacking me or making a direct statement about my competence because I'm not doing something. So just be mindful of that. There is this other way, which is called the 5-step advocacy. First, you have the personal attention. So those are some of the examples that I used specifically created exclusive for the airway. So you can say something like, excuse me, can you please clarify what capability you need? And then you can state your concern. You can say, that's already the 4th attempt at intubation. And then you may say specifically why you're worried. I'm worried that this may cause bleeding and make it harder to backmask ventilate. Because one situation that could occur, it was hard to deintubate and was easy to backmask, and the person is comfortable. But if you keep trying and trying and trying, eventually this could cause bleeding, edema, and now the backmask ventilation is also not easy. So you can say first, can you please clarify the equipment? Oh, that's already the 4th attempt of intubation. I'm afraid that this may cause edema and bleeding and may affect backmask ventilation. And would you like to consider a supraglottic airway, or do you want to consider waking up the patient and obtaining agreement? Would that be all right with you? So this would be an example of how to state your concerns in a 5-step advocacy for an airway emergency. You can always use the cognitive aid, and the cognitive aid, if it's visible, if the other people in your institution are familiar with it, it becomes a very easy way to navigate why you're bringing up those concerns. Oh, you already tried multiple times trach intubation. Do you want to consider this one? You already tried this face mask not working. Do you want a size 5 in the mask instead of the size 3? Like if you have this cognitive aid readily available, it's easier to identify why you're doing this talk, why you're bringing up those concerns. And I also want to bring to your attention one problem of communication in an emergency, which is the lines of communication. If you only have 3 people, you only have 3 lines of communication. But as you add people, it doesn't add just one more line of communication. 4 people, now you have 6 lines, and 5 people, now you have 10 lines. Like different ways that people could be talking to each other. And you can see how this can increase, how it increases exponentially. And it's not unlikely that in the middle of a cannot intubate, cannot ventilate situation, you might have 10 people in the OR at that point. 10 people in the OR, now you have 45 lines of communication. It is going to be complicated for people to know what's happening. It's going to be if each person is just talking to each other, as opposed to have a more structured way of communicating. And that's why it becomes important to have the team leader, and the communication should flow through the team leader. Instead of people just talking to this one and this one talks to this one, everybody basically stated their concern to the leader, and from the leader goes back to some other person or to the whole group. But the communication should flow through the leader as opposed to each other. Otherwise, it's just a mess. And closed loop communication is a concept that is often utilized in emergency management. And the idea is that once the team leader gives an assignment to somebody, this person acknowledges and then waits for the confirmation. And once the task is completed, they look back to the team leader. So it's not something like, can someone please bring me a glide scope? No, like you should be to a specific person if possible. Please bring me the glide scope. And then the person acknowledges, looking in their eye, okay, bring in the glide scope. Oh, glide scope is here. And then confirm. It's not only bring the glide scope and bring to the OR and doesn't inform the team leader that the glide scope is there. Someone starts an IV, start another IV. No, it's like, start another IV. Oh, you want me to start another IV? Yes. Okay, IV is in. So you always confirming the instruction that you received. And then once the task is done, you inform back to the team leader that thing is done. And that's very important, not only so they can keep track and you keep it more organized, but the clarification is important because, well, I have an accent. I might say to please administer one drug, and you might hear something else. And on the confirmation, that you might identify that what you understood is not what I said. So this is important. You give the instruction, acknowledge, confirm that's what it is, yes. And once you do it, you inform that it's done. So trying to tie back to the objectives of the talk, identify features of difficulty in airway management. So it is the bones, if you're expecting bones for the difficult bag mask ventilation, RODS is the acronym for difficult laryngeal mask insertion, and LEMON is the acronym for difficult intubation. So basically know that there are anatomical features that may make airway management more difficult. And there is also clinical situations that even though anatomical features are easy, that situation may make intubation harder in the sense that the patient might desat quicker, the patient might have cardiovascular collapse during induction. So identify those features so you can avoid the unexpected difficulty. But if you do have the unexpected difficulty and you could not intubate, you could not bag mask ventilate, and you could not do the laryngeal mask insertion effectively, now it's time for emergency front of the neck access. And the current recommendations for emergency front of the neck access is scalpel, blade 10, bougie, and a size 6 endotracheal tube. I'm focused exclusively on adult. I don't do pediatric practice. So that's what you do in a cricothyroidotomy: scalpel, bougie, tracheal tube. I know that there are some communication tools that may be useful for airway emergencies. Just doing the technical stuff is not so hard. It's to make the decision and communicate effectively that is hard. So communication tools, you have the cognitive aid, which is the vortex approach. If the whole team is familiar with that, it's easier to bring up your concerns because everybody's on the same page. If you're trying to bring a person's attention and it's not working, you can use that graded assertiveness. I'm concerned. this is unsafe. I'm scared. So CUS. And hopefully you will have a sort of institutional support that does not punish people who will speak up when needed. That's it. I spoke a lot. I hope you guys are still awake. I have no feedback to know how people are receiving. I'm all done.
Thank you. That was excellent. Thank you very much, Dr. Cordovani. I hope everybody can hear me. Yes. Look at all those hearts and thumbs up. So they loved it. I did want to just comment on the communication, highlighting the communication. I think that is so valuable. So thank you for making it so clear to our members who have joined us this evening. Across the province, I can see that we have membership from Sudbury to Hamilton to Niagara Falls, to back down to London and Ottawa, etc. So many areas represented this evening. Are there any questions for those on the webinar tonight? We'd invite you to put them in the chat. That's probably the best way, or the Q&A is fine, either or, and I'm happy to moderate those. We'll just have a little look and see what's there.
I see there is a question, say, elective surgery, best to wake up the patient.
Yeah. Mm-hmm.
I will address that because, of course, the answer to many of the questions related to it is a big depends. So it's not exclusively because it's elective. It depends on what was the difficulty. If you could not intubate and you can bag mask ventilate, you could probably try again with a different, basically you shouldn't be insisting on the same thing that didn't work. Maybe you try direct laryngoscopy, maybe you should try now video laryngoscopy, or maybe somebody else should try, change the device or the person. What surgery is, maybe it's if it's I don't know, a big abdominal surgery or laparoscopic procedure, it would be very challenging to do with a laryngeal mask, but if it's like, I don't know, bunion repair, you can do with laryngeal mask. So maybe your initial approach didn't work, tracheal tube and face mask is working. You might be able to get away with to try again or to use a different device. But if it is a situation that for the surgery to happen, it is very important, or it is crucial for the person who have a tracheal tube, it could not be done with a laryngeal mask, for instance, and you already tried maybe 2 or 3 times and it didn't work, I would argue that at this point, yes, you should wake up the patient. But the wake up of the patient is you cannot intubate, but you can bag mask ventilate. If you cannot intubate and you cannot bag mask ventilate, you don't have the option to wake up the patient. Like the time that the clock's ticking. At this point, you have to advance for this emergency front of the neck access. It doesn't matter if it's elective or emergency. If you cannot intubate, if you cannot, if you're exhausted, your 3 ways: intubation, laryngeal mask, and the face mask, you have to do emergency front of the neck access. Some people have, well, sorry, there is something else that comes to my mind, I'll address in a moment. But so the waking up patient, I would say that is reserved for elective situations in which you could not intubate, but you could bag mask ventilate. So you have the luxury of time. You are in the green zone. If you are bag mask ventilating, you're in the green zone, you have time to think and decide what to do. And then you can reschedule the surgery to another day, and then you can try to do an awake intubation in the next situation, because now you know for a fact that it is hard. Some people will say, why not wake up the patient and just do an awake intubation at that point? And the problem with that is the intensity and the frequency of airway instrumentation. Because if you tried it 3 times, for instance, to intubate and you couldn't intubate, maybe at this point you could still bag mask ventilate. But if you keep attempting, now you could have a whole bunch of edema that bag mask ventilation might not be effective. And the other problem is we talk a lot about failed intubation and emergency in airway intubation, but a lot of the airway tragedies actually occur on extubation. And there is a direct proportion of increase in the failed extubation the more attempts you have. So if you tried 2 times to intubate a person, this person is likely two times as likely to have a failed extubation, and increases in direct proportion. So if I already tried 3 times to intubate a person, I was not effective, elective case, I should probably give up, reschedule the surgery, and do the surgery and do awake intubation some other day, because if I still try today, I might be effective with my intubation, but there is a greater chance that when it's time to extubate this person, because of all the trauma, edema that will be occurring during surgery, when I extubate that person, this person could have an airway emergency on extubation. So that's why waking up is in the back of the mind of the anesthesiologist when we cannot intubate. But if you cannot intubate and cannot ventilate, you have to do emergency front of the neck access. And as I mentioned, I'm very repetitive. That's my teaching style. I apologize.
Are there any other questions from registrants on the webinar this evening? I will go ahead and just answer the one to everyone with respect to the presentation this evening. It will be archived on the ORNAO website, and you will receive a certificate from our IT consultant and a link to the presentation once that's prepared. So stay tuned for that. And just looking at the questions, excellent. Thank you very much.
Is it okay if I go into my the thought that popped into my mind that I thought I wanted to?
Please.
Many of you have heard of Sugamadex. Sugamadex is, if you have not, Sugamadex is a reversal agent specific for rocuronium. It doesn't really work with cisatracurium or other, but Sugamadex is an agent that will reverse rocuronium very quickly if you do the appropriate dosage. So typically when you use paralytic agents, and if you were to reverse with a neostigmine, it will take longer, and you can't just give neostigmine at any moment. If you just gave rocuronium and you give neostigmine, it's not going to have an effect because all the acetylcholine receptors are taken. So it's not really going to work. Sugamadex, on the other hand, think of it as a sponge. If you give Sugamadex, it's going to suck the rocuronium out of the receptors, and you're going to reverse the paralysis very quickly. It's an amazing drug, but I find it quite problematic because it started to be perceived as a magical drug that if you cannot intubate, cannot oxygenate situation, you give Sugamadex to wake up the patient. What people are trying to say, you want patient to resume spontaneous ventilation. But I find that this perception of Sugamadex as the drug to give in the cannot intubate, cannot oxygenate situation, I find it dangerous. And even in my own institution, if you're using Sugamadex, they ask for the justification of when you're grabbing from your Omnicell little thing, your machine to get your drugs. They ask why you're taking Sugamadex, and the first option, it's written over there for you to click, is cannot intubate, cannot oxygenate. This is, in my mind, wrong. Wrong. If you cannot intubate, cannot oxygenate, you do emergency front of the neck access, because if you cannot intubate, cannot oxygenate, if you think about the airway guidelines recommendation, the first thing that they ask is the patient paralyzed? Because maybe the reason why you cannot bag mask ventilate the person is because they have a laryngospasm, so you paralyze them. Or it's harder to do the laryngoscopy because they're not fully paralyzed. So paralysis is to facilitate your intubation, is to facilitate your bag mask ventilation. Reversal for the paralysis, that's what it does. It reverses the paralysis. It does not wake up the patient. So I find it problematic to imagine that you give Sugamadex and that's going to magically wake up the patient and make this person resume spontaneous breathing. And no, you're just going to remove the paralysis, but likely you gave other induction agents. It's going to be very hard to reverse the effect of the reversal of those other agents that quickly. Particularly problematic if it's an emergency intubation, like a person who was already with cardiovascular collapse, or a person that had some sort of respiratory compromise that made you decide that intubation was important. At this point, you gave your induction and your rocuronium. If you give Sugamadex is not going to make the person's clinical condition better. They still have the same condition that they had before. So the expectation that they will magically wake up and resume breathing, I think is misguided. So Sugamadex, I think, is a very useful drug, but the main usefulness of Sugamadex, in my opinion, is the situation that I could not intubate I could bag mask ventilate, and now I decided to wake up the patient. Because if I were to use a new statement, I would probably have to wait a good 30, 40 minutes until we would be able to reverse. And I would have to be bag masking that person for 40 minutes. Versus if I could not intubate, can ventilate, and decided that I'm going to wake up this patient. Now I give Sugamadex, reversal is done. I'm just going to have to bag mask ventilate this person a few more minutes until they wake up. So that's my little rant about it, because I find it problematic. We're seeing, are we seeing awareness? I didn't quite understand the question about Sugamadex. Are we seeing awareness in literature when used to reverse? I didn't really understand the question.
Well, it's Denise. So I'm just thinking about what you were saying. And if a patient is not paralyzed, you've reversed the paralysis, but they still have narcotics and other cocktails for induction. Is there a potential that they would have awareness then? I'm just curious. No?
So for the sake of simplicity, I'll say no, because what's taking their awareness away is the narcotics and the induction agents. The paralytic agent doesn't take the awareness.
Yeah, you're right. I'm sorry.
Awareness would be the opposite. Awareness would be the opposite. You have the paralysis and you don't have the other agents.
Yeah, you're right. You're right. Okay, I thought that through. Thank you.
No, but you would eventually have awareness, but that's what you want. I mean, if you want to wake up the patient. So yes, so you did the induction agents and the rocuronium, you failed. Now you reverse the paralysis. And that's what you want. You want that by the time the person wake up, they're no longer paralyzed, because the problem is to be awake and paralyzed, which is the ultimate torture.
I guess I'm just thinking, that's what I'm thinking about. Would there be that episode where they would have that awareness, but they'd still be narcotized, etc. So okay, great. Thank you. Are there any other questions out there in the those that have joined us this evening? Nothing in the chat at this point. Lots of really great feedback, Dr. Cordovani. Really thank you. We'll wrap it up for this evening.
Oh, my pleasure. I really would like to encourage you, I will focus on the communication component. Don't think that because it's the anesthesiologist or the intensivist, so don't think that because of that, they have ultimate power or decision making. I think it's very important. We can all fall into task fixation or lack of overall big picture. So the nurses play a crucial role in every once in a while prompting. I don't know. I know it's problematic. I know that it's not easy always to deal with all the types of personalities we encounter in the OR, but I would send a word of encouragement, do it. If a person is disrespectful to you because you spoke up about patient care, it's more of the other person's problem than yours. It's not pleasant to be the recipient of another person's unpleasantness. But I think it's worthwhile the risk. In the case of Elaine Bromley, 3 experienced anesthesiologists, they knew what to do, but they didn't do it because they were all victim of task fixation. The nurses recognize that when you are not cognitively involved in the task, when you are not the one doing the task, you are more likely to perceive problems than when you are involved in the task. So the nurses will have a very powerful perception of the situation because they typically are not the ones doing the intubation themselves. So they might perceive things that the anesthesiologist will not perceive. They speak up. In that situation, they try to speak up, but they didn't speak up effectively. They kind of gave indirect. Watch that video. They kind of gave indirect hints. They bring the kit into the room, but they not really assertively tell them, you already tried so many times. I think you should consider this.
Thank you for raising the Bromley case. The video is excellent. I have watched it in the past, and it really does identify a number of errors that were made that could have led to a very different outcome for that family. So thank you. That communication piece and the illustration in that video is really meaningful and worthwhile. So take the time to do that if you do have the time. Just going to make sure the chat's empty. Yes, nurses speaking of ineffective. Yes, absolutely. We need to all advocate for our patients, but also to be kind and collegial at the same time, which takes a bit of practice. So think about what your comment might be, and maybe think back to Dr. Cordovani's, I'm concerned, I'm afraid, etc. Really great communication techniques there to get you through those hurdles in your clinical practice.
It should work two ways. You should work to teach people and encourage people to speak up, and also train people to acknowledge when somebody's speaking up to them. It's both ways that we have to address that.
Really pleased tonight with our number of our attendees this evening. Really want to encourage everybody to continue to spread the word about our provincial group revitalizing, and to Dr. Cordovani for kind of setting off our fall series tonight in such a tremendous way and sharing your insights. I think everybody's learned something tonight, and certainly reinforced some of the techniques that some of us are using. I'd like to remind everybody that we do have another upcoming presentation in October on the 17th. So if you haven't registered, please have a look at that. That'll be sponsored by Ethicon around biosurgery hemostasis, as well as addressing surgical site infection risk factors and discussion on some of their antibacterial sutures, excuse me. And then I would also like to say that we've sponsored tonight for Dr. Cordovani to be with you all. So thank you so much for joining us. And I think with that, we will say thank you very much. Good night, Dr. Cordovani.
There was one question that I would like to not leave unaddressed. The question
yes,
was
please.
how many times I will allow a medical student to attempt intubation? Typically one, with rare exceptions. Let's say they were almost there. I'm confident there were maybe, but typically one. But I will say one thing: before I allow a medical student to try an intubation, I verify if I can bag mask ventilate the patient. So if I can bag mask ventilate the patient, I am already calmer, because I know if they by any chance fail to intubate, at least I have the other way to keep the person oxygenated. If I try to bag mask ventilate the patient and I cannot, this is not the moment to teach. This is the moment that I will try, because the patient is in the vortex. One of the three ways is already not effective. So now I already have two more ways, which is supraglottic. And so if I cannot bag mask, then I'm just going to take over this airway management. If I can, the student probably will try once.
Thank you for reviewing that. That's excellent that we know the thought processes. So very methodical in terms of the work, the care that you provide. Thank you very much.
Thank you, guys. It was very nice. Thank you for inviting me for this.
Thank you very much. And I'll see you soon when I get back to work.
Enjoy.
Hey, everyone. Enjoy the rest of your evening, and keep tuning in. I look forward to our membership numbers increasing. Really looking to build our membership this fall, and also have more vendor sponsorship in terms of giving you great presentations like tonight that really impact our clinical practice and help with the teamwork as well. So thank you once again from the ORNAO board. We appreciate your time. Good night, everyone.
Right.
Good night.